Hello, everybody. It is a great pleasure to be part of this course and event. Fetal MR is a brilliant topic. I really love it. It's my heart and soul here. And I'm happy to share my presentation on early gestational scanning with, of course, using MRI. This is the place where I'm working at the Medical University of Vienna. Now, if you look into the first trimester, and this is probably known to everybody of you, ultrasound is the method of choice. We have a vast amount of literature coming from ultrasound in first trimester ultrasound. And it's important for us also to know that many disorders are currently diagnosed at very early time points. I'm speaking about TRA2 malformations being seen with its early signs at 12 gestational weeks by scanning the intracranial translucency, and this is quite a reliable sign for ultrasound experts already. So disorders we have been used to talk about as pediatric neuroradiologists for years by talking about children are now seen at the embryonal fetal, early fetal stages. And it's just important to understand that with MRI, we are here entering a field of very early scanning, which is already occupied by ultrasound with years of experience, as you can see here on this PubMed profile on first trimester ultrasound with over 11,000 results. This is fetal MR reference data. Of course, recently other papers were added to that. It just outlines when you're looking at fetal MR reference data, it's mainly happening after 24 weeks in most of the studies. Some studies go before that time point. Very rare studies go even before 20 weeks. And if you look at the references and case numbers before 20, it's really, really low. I would call the period after 24 weeks as regular scanning. Everything before that, I would rather regard as early scanning. And before 20 weeks, I would even address as super early. Now, we have guidelines, and these guidelines state that fetal MR should be actually performed after 18 weeks, because before 18 weeks, and that's in the guideline, it does not usually provide information. In some cases, you might consider even doing MRI before 22 weeks, and generally, it's good between 26 and 32 weeks. Now, there is also the notion that maybe if you consider that fetal MR adds some information to ultrasound, you might start thinking about doing it also at other time points, but you always have to combine it with good ultrasound. And I think we all agree on that. These two methods go together. We need to collaborate with our referring physicians, and these are prenatal medicine specialists, and they are in many places of the world obstetricians. Now, in order to really go early, I would like to go through a very systematic approach. We first have to talk about safety. We also have to talk about technological challenges when performing fetal MRI. We have to define normality at early time points, look at reference data, and then try to bring it to the point of care. Now, MRI safety, you're all familiar with that. We can feel safe in doing MRI because fetal MRI is safe. There is a vast reference data right now published where there is no single sign of adverse effects by using this methodology at prenatal stages. I also want to stress that a lot of safety studies are performed in the MR field with maximum exposure. In reality, be also aware that when you're performing fetal MR, a rather small time of MRI examination you're spending in really acquiring sequences where the vast majority of time is spent on planning and not really exposuring the fetus to actually SAR intense sequences. Now, heating and SAR are the important aspects of safety. We know that if we increase body temperature in animal models above 2 degrees centigrade for a longer time, we might also induce anomalies. So there is also some safety concern as long-term effects of heating in a developing individual are largely unknown up to this point. I have to also stress that also when you're doing ultrasound, you're heating the tissue, not immensely, as you can see here, certainly below 1 degree centigrade body temperature, but at least you're doing some exposure here. And if you run an MRI on normal level, you're only basically be able to increase body temperature up to 0.5. first level 4 watts per kilogram, 1 degree Celsius. So this is all well below this mentioned basically border of 2 degrees Celsius. We of course have to be aware, we have to monitor this method, and particularly when we are going before 18 weeks, but generally we currently do not have a really strong concern of also using MRI at earlier states. If we move to 3 Tesla, we know also from recent publications that if you expose 1.5 and 3 Tesla, it's sort of similar in terms of SAR. Also keep in mind that if you're exposing a fetus to increased energy, most of this energy will be deployed to the mother and not really to the fetus itself. So also the majority will be deposited in the maternal body and does not go into the fetus, as in this study is nicely demonstrated. So it's only half of the maternal SAR which is getting to the fetus. And keep in mind, there are sequences with more SAR, particularly the TrueFISP SSFP sequences. They are very useful. I know they are working horse of fetal MR, but if you run them very frequently after each other, there will be heating. Also, noise is a point of interest, but currently we do not have any indication that there are hearing defects in children exposed to 3 Tesla or 1.5 Tesla fetal MRI. Now, the technological challenges are vast. You know, motion is a huge issue in fetal imaging, particularly if you're not using any sedation, as we are doing here in Vienna. So all the sequences and images you're seeing and going to see here are done without the use of a sedative medication. The size is another issue. If you look here, the ground rump length of a fetus at 14 plus 2 gestational weeks is 9 centimeters. This is very, very small. You need a certain resolution to really be able to diagnose something here. The biparietal diameter here in the head, for instance, is about 3 centimeters. So you're looking at the structure which is around the size of your nail. So really very small dimensions. Now, this is a case seen on ultrasound with suspected body stalk anomaly. If you also adjust your field of view, and you can do that in early pregnancy, the dimensions of the mother are smaller than compared to later stages, so infolding artifacts are less frequent. You can see that there is a fetus with a huge externalization of liver, even parts of the heart, of abdominal structures, and also the bladder seems to be enlarged and outside of the body. Moreover, and this was an additional information provided by MRI at 14 plus 2 gestational weeks, was this spine deformity with a meningocele back here, which can be detected at this early point. You might ask, why should we do all that? Well, sometimes it's good to have a second confirmation of an ultrasound finding, at least in our culture. Pregnant women undergoing a termination of pregnancy, this is really a very severe thing. You have to imagine the psychological consequences of such a thing, and at least here in Austria, women want to be very sure and safe that their decision is based on really findings they can trust. And at least here they feel that if you have a secondary examination providing and supporting the ultrasound findings, it makes their decision more confident, and actually the psychological adverse effects are lower. Now, here you see also that you can assess the brain even at 14 weeks with these large ventricles, thin brain parenchyma. And we also tried to do some tractography here and found a fiber, but I'm not claiming that this is really something we can trust. Now, at early gestational time points, we have to get familiar with the very, very early brain anatomy. And that is challenging by itself because there is not much of reference data. We are looking here at 18 gestational weeks, 17 plus 1 to be exact. And these are conventional T2 TSE sequences. And you can actually nowadays use AI to optimize these sequences and use a convolutional neural network in boosting resolution, and in our case compressed sense. This is a combination which can improve the resolution and detail you can see. And if you do that to this early case here, you get image quality like that. With that, you can see a little bit more than before. it's also good to see and understand that this was before and this after, that there are no structures kind of put into these images by the EI reconstruction. It's really enhancing what is there. And you see that there is a corpus callosum already visible on multiple planes. You can see the septum pellucidum nicely. And if you compare that to the corpus callosum, you can actually combine these observations. Some of these structures, I believe, are even more elegantly seen on this MRI scan. And this is a very interesting part, because I was always wondering what's in between the tectum here and the splenium of the corpus callosum. And actually, this is the roof of the third ventricle. In that way, you do not see it later, but it's very prominent at these early time points. And that was also confirmed here by this early preparation by Hochstetter, who is from Vienna, and he actually also indicated this as the roof of the third ventricle, combining, basically connecting the splenium of the corpus callosum and the quadrigeminal plate here. Now, in early time points, you can also look into these early proliferative zones around the ventricle and subventricular zones, which are dark due to their cellularity on T2. And if you run a flare sequence, you can also see this hyperintensity, which is more bright than the cortex, indicating that there are a lot of cells in there. In between, you have the developing subplate already also visible at early gestational time points. We start seeing that on MRI between 13 to 14 gestational weeks. Now, this is 18+3. These are axial T2-weighted sequences. This is the flare. Again, note that the periventricular zones are brighter than the cortex at these early gestational stages, indicating that there are more cells in there. If you also run these advanced techniques, you get even a more crisp delineation of these zones. And of course, here, the ganglionic eminence. And sometimes you're lucky even at these earliest time points and get some corticospinal internal capsule fibers as well. On rectography, this is the postmortem MRI. Here at 14 gestational weeks, a very nice image provided by Christian Mitte, my colleague here in Vienna, showing that the ganglionic eminence is a very prominent and impressive structure at this early time point, which can be appreciated by MRI also at these early stages. Now, this is the subplate formation phase. I mentioned it already, 12 to 14 weeks, unsupported image after AI reconstruction. You get a really more crisp idea of this structure right here of the subplate by seeing these absolutely better than in the unsupported image. And again, I feel this is reality. This is not something which is made up by any algorithm. It's just information which is there, but read out in a more efficient way. Now, we have checked actually the normality. We have addressed technological challenges. Now we have to go into the point of care. Neural tube defects are amongst those cases which can be picked up by ultrasound very early. And they might also require early MRI confirmation, so you can actually see an obliterated intracranial translucency representing the fourth ventricle at as early as 12, 13 gestational weeks. Some people, like Rabbi Schauer in Berlin, might even see it earlier than that. And if you do early MRI, you can save some time while doing genetics. This was such a case, suspected neural tube defect at 17 gestational weeks. And what we saw is this lemon sign, but what we then saw in detail, that there were two defects right here, occipitally. And we also saw that there is a connection with the subarachnoid space. So this was a meningeal seal, in fact, two meningeal seals, even with some stalk towards the cerebellum, tectocerebellar dysraphism, whatever you want to name it. But generally, this is a typical feature of this Chiari constellation supratentorially and these meningoseals. Now, this is the case at 14 plus 2 gestational weeks. You will already realize that the shape of the brainstem looks different. Also, the shape of the cerebellum. After AI super resolution visualization, you get a little bit more crisp idea of the entire situation. But what you also can see very well here is that there is something sitting right here, which you may not have appreciated very well in this unsupported image. And this is the axial one with a more crisp visualization at these early time points. And this was, again, a small meningocele right there. 18 plus 4, again, a Chiari aspect of the fetal brain. We have some hind brain displacement, small posterior fossa, and a myeloschisis right here. And what you also see is that this brain parenchyma here looks quite bright. And if you wonder what this is, please go ahead and read the papers by Hui Shi. A series of papers came out this year on fetal brain edema in KRA2. This might be an indicator for particularly poor outcomes in KRA2, which can be potentially solved by fetal surgery. We are looking into that currently and see if this is a parameter indicating particularly good outcomes after surgery. Brain edema is connected to various other clinical outcomes. You see cases with brain edema have worse motor level, they have higher rates of hydrocephalus, they have higher rates of neurogenic bladder. So generally, this seems to be really a group of cases where fetal surgery might be particularly beneficial. Abnormal gyration might also something which can be seen on ultrasound and confirmed on MRI. Here you see these abnormal undulating midline in a case of a Curry-Jones syndrome, very rare situation. Also here at 12 plus 5 gestational weeks, hugely abnormal brain on ultrasound and MRI involving the posterior fossa. Here you see that the brain stem anatomy, but also the cerebellar anatomy is completely, entirely confused. We also have an exophthalmos with this eye being pushed out more. So a really complex situation. Unfortunately, we did not get any sort of genetics in this case because the mother denied to do genetics. Cerebellar development, you all know that, is driven by the external granule layer, particularly in those stages where we used to do fetal MR after 24 gestational weeks. Before, we have to look into another driver of brain development, and that is the rhombic lip. And actually, we can really see this rhombic lip by its high cellularity and dark D2 signal at 16 and 17 gestational week right here. This is a case of rhombic synapsis. What you see here is not the vermian tail or rhombic lip. This is actually, there is no vermis here. This is a fusion of the vermian hemispheres at 17 plus 3 gestational weeks. So if there is already early ventriculomegaly, you might be successful in doing MRI and detecting that and supporting your colleagues on ultrasound, who of course also have done the diagnosis of rhombic synapsis of 17 gestational weeks and earlier already. But as said, another supporting method would be advisable, and sometimes in severe ventriculomegaly or moderate ventriculomegaly, rhombic synapsis might be the cause, and you are the one taking that call. Now, rhombic lip, I mentioned it already, is a hot topic currently. This is 16 plus 3 with a lot of features of a Dandy Walker phenotype. You see that we do not really see a good fastigium here. We see this vermian tail and maybe attached some membrane here. And normal brainstem. This is the coronal view. You see these dark shadows right here, which might be the choroid plexus. This is certainly not the strength of fetal MR. The choroid plexus is much better seen on ultrasound. And also, this is the post-mortem sample where you can actually see this upward rotation of the vermis. This is the representation of this vermian tail. And you basically, as usual, do not see any membranes because they are kind of removed in most of the neuropathological cases. What you can also see on MRI, and this is an exciting chapter, I believe, at early MRI, you can look into the placenta. And this placenta seems to be thickened, a little bit heterogeneous. And if you look at the recent literature here, which states vascular insults causing rhombic lip structural damage from 13 to 14 gestational week onward contribute to these abnormalities. By looking at this case, I would really say that maybe the time frame of 13 to 14 weeks is late. I would really push that even a little bit further, 10 to 12 weeks maybe. But MRI gives us the chance to really look into the placenta and the brain at the same time, which makes it, I believe, particularly exciting. So if you also do some AI reconstruction, these structures really come out really better, also at very early time points, and you can see this vermian tail sign very well. Here again, another case with abnormal placenta. Our data with network medicine analysis showing that cerebellar hypoplasia, vermian hypoplasia is frequently associated with umbilical artery changes, but also placental changes. Now, with that, I would like to finish my presentation. I hope that I could convince you that we can systematically approach the time period before 18 weeks from a safety standpoint, from a technological standpoint, but also from a medical standpoint, we have still to learn a lot in that stage of development. But from my view, we have to learn because ultrasound is making huge strides in very early first trimester diagnosis. To keep MRI, fetal MRI as a method after 30 weeks will take us a little bit out of the business in contributing our expertise. And for that reason, I would really like to continue exploring these methods at early time points in pregnancy. With that, I'm very happy that you kept on listening, and I'm convinced that this course supported the idea of learning fetal MR as a substantial part in our radiology practice and stimulate you doing this also in the future. Thanks a lot for your attention. Thank you.